Why are erections impacted when men have surgery for prostate cancer? This is one of the most common questions that I get during my clinical practice as a urologist and director of the prostate clinic located here on the Gold Coast in Australia. If you or a loved one are about to have a radical prostatectomy, the surgery to manage prostate cancer, then please watch this video. It may provide you with some information to help you be better prepared for the future. As always, if you get benefit from this video, please hit the like button, subscribe to the channel, and as always, leave a comment, a question, or share your experience if you're prepared to in the comment section down below so other people can learn from you along the way. Okay, as a way of background, the mechanism for normally having an erection is dependent on a couple of things. It's dependent on a normal blood supply and a normal nerve supply. And in essence, the nerve supply and the blood supply of the penis are located on what's called the posterolateral aspect of the prostate. The technical term that we use is the neurovascular bundle. So the neurovascular bundle, there's a right and a left one. They are plastered onto the backside of the prostate and course through that location to head off to the erectile tissue of the penis. Now, under normal circumstances, erections happen when men have normal blood supply, normal nerve supply. But as we progress through life, that nerve and blood supply can change. It can change if we carry too much weight, if we have diabetes, high blood pressure, elevation in our cholesterol. It can change if we've been a lifelong smoker or potentially have had radiotherapy to the pelvis previously. The older we get, the greater the potential for a variety of different risk factors to affect both nerve and blood supply, and therefore it's very common as we age to notice a decline in erectile function. Now, when we're coming to surgery to manage men who have prostate cancer, one of the critical aspects that we look for is to determine our ability to spare those neurovascular bundles. And in essence, one of the key criteria really depends on the prostate cancer profile. And what I mean by this is we are looking to determine how aggressive someone's cancer is, how big someone's cancer is, but specifically, where in relationship to that neurovascular bundle is a man's cancer. Now, conceptually, if that cancer is in close proximity to that nerve, and we think that there is a greater probability of that nerve breaching or spreading through the shell of the prostate, then our ability as clinicians or surgeons to be able to safely spare that nerve is reduced. The analogy that I use with my patients day by day is that the nerves or the neurovascular bundles are plastered on the back of the prostate, and the way that we remove them is analogous to peeling an onion, in that we cut a layer that is on the very outer shell of the prostate and we peel that layer away. Now, obviously, if someone has cancer that has breached through the shell of the prostate and we peel that layer away, there is potentially a greater risk that cancer cells can escape and flick off because there's no longer a layer keeping them contained. So, for example, if someone has primary pattern 4, so on the Gleason score, if they have a higher grade or that initial score is a 4, if we can see a large lesion on MRI and or on the PET scan, if that spot is palpable, if your surgeon, if your urologist can actually feel that cancer in the location that is close to the neurovascular bundle, then these are indications that we use from a cancer risk perspective to not be as aggressive in sparing that nerve. Ultimately, if we don't spare nerves, the probability of erectile function reduces. If we are able to spare nerves and someone enters into surgery with good erectile function, they're what we call young, less than 65 years of age, younger, and they have no risk factors for erectile dysfunction, then the probability, if we spare both of those nerves, then the probability that that man recovers his erectile function is higher. If someone has diabetes, if they have high blood pressure, if the cancer is in the area where the neurovascular bundle is, then our ability to spare that nerve is reduced, and the probability that that man regains erectile function is therefore lower also. It's also important to be aware that the duration with which erections recover following surgery is relatively slow. Most men, even when we spare nerves, most men develop something called a neuropraxia. Technical scientific name. It basically means that the nerves are spared, but the nerves are bruised and they don't function properly. The best way to think of a nerve is that it's an internal cable that conducts electricity from A to B. And if electricity goes from A to B in a normal, rapid fashion, things at B work well. If that nerve is bruised, then the number of electrical impulses along that cable reduce, and the intensity of those impulses is also reduced. And therefore, what we see at the endpoint at B is reduced. If you have questions, comments, or thoughts, please leave them in the comments section down below. If you'd like to know more about your prostate, please have a look at this video, or alternatively, have a look at this video. Until the next time, take care of your prostate.